Hi guys, good morning.
Good morning.
Hey,
How are
how are
you?
you?
Good, how
I'm
are
good.
you?
I'm good.
Okay. So we did before the immune privilege slides, I think.
Right.
Okay. So let's try to aim. We cannot finish the article, I don't think so. That's up till here. Okay, let's see. Nupur, can you ask the Zoom user who is that? I think you're not connected to the. Yeah, go ahead.
What will you
Okay.
Can you hear me?
Now I can hear you.
Okay. Okay.
Okay. Large B-cell lymphoma of immune privileged sites. There is a one person named Zoom user. Can you please tell me who you are? I'll just rename you. Can you see yourself in Zoom user? I'll have to remove you if you don't tell me. Either rename yourself or tell me. You can put me in the chat as well personally.
If they don't respond, then I can always remove them until they rename themselves.
Yeah. Okay, I will be putting you in the waiting room so you'll know who you are.
Okay. He or she just said their name is Razan.
Okay. Okay. Yeah, because we have had some bad experiences before
Yeah.
with people
Yeah.
entering in. I'm gonna rename you then.
Yeah. No offense to anybody, but that was a very unpleasant experience. So we will be cautious.
Yeah, exactly. Right. Okay. All right. So let's get started. Large B-cell lymphoma of immune privileged sites is a new umbrella term introduced in WHO Heme 5 to acknowledge common biological feature of group of aggressive B-cell lymphomas that arise in primary tumors, so in CNS, in vitreoretinal compartment, and in testis of the immunocompromised patients, of the immunocompetent patients. This new entity now combines the previous entity of DLBCL of CNS with DLBCL of vitreoretina and testis that were previously included among the DLBCL NOS. So DLBCL of CNS and then the vitreoretina and the testis were included in the NOS category previously. They arise in immune sanctuaries created by their retinal and blood testicular barriers and immune regulation systems within their respective primary sites and share immunophenotypic and molecular features. Information on this group of tumors is rapidly accruing. It appears that some lymphomas arising at other distinct sites, such as the breast and skin, share some of these features, and thus this group of immune privileged lymphomas might expand in future classifications. So what are these? Okay, so CNS, vitreoretinal, and testis of immunocompetent patients. Next is fluid overload associated large B-cell lymphoma. So it's a new addition to the list of large B-cell lymphoma in the WHO Heme 5, being distinct from primary effusion lymphoma. This entity has been, so it is distinct from the PEL. And this entity has been briefly alluded in the fifth edition of WHO classification of thoracic tumors under the names PEL-like lymphoma or HHV8 unrelated PEL-like lymphoma. The patients usually are adults, predominantly elderly, without underlying immunodeficiency, who present with exclusive involvement of the body cavities, most commonly the pleural cavity. and they frequently have underlying condition. So the patients are usually adults, predominantly elderly, and without immunodeficiency and in the body cavities and pleural. They frequently have underlying condition causing fluid overload, so such as chronic heart failure, renal failure, protein losing enteropathies, or liver failure and cirrhosis. The neoplastic large cells exhibit mature B cell rather than plasmablastic immunophenotype. So yeah, this one is a mature B cell immunophenotype. KHSV and HHV8 is negative, and EBV can be positive in 13 to 30% of the cases. And the genomic landscape differs essentially from PEL. The prognosis appears to be fairly favorable, yet another distinction from the PEL. All right, so that's your fluid overload associated high-grade B-cell lymphoma. And then next is the mediastinal gray zone lymphoma. So mediastinal gray zone lymphoma is a B-cell lymphoma with overlapping features with PMBL and CHL, especially nodular sclerosis CHL. This entity replaces the term B-cell lymphoma unclassifiable, which features intermediate between DLBCL and CHL of W4R. Taking into account that lymphomas with these features are specific to the mediastinum and are part of single biological group with a morphologic and immunophenotypic spectrum from CHL to PMBL, with marginal gray zone of mediastinal gray zone lymphoma straddling the two. Current evidence indicates that cases with morphologic and immunophenotypic features similar to mediastinal gray zone lymphoma, but occurring outside and without involvement of the mediastinum, harbor different gene expression profiles. So that's important. Extramediastinal have different gene expression profiles and DNA alterations, and they will be characterized as DLBCL NOS. So basically, PMBL plus CHL type, especially nodular sclerosis CHL. So that's similar, just that they have changed the name and they have removed the extra mediastinal from those entities. High-grade B-cell lymphoma NOS represents aggressive mature B-cell lymphoma composed of medium-sized to blastoid cells that do not fit other well-defined entities. NGS-based analysis of the mutational spectrum and gene expression signatures suggests that high-grade B-cell lymphoma NOS is heterogeneous category, also including activated B-cell lymphomas with mutations of MYD88, CD79B, TBL1XR1. Most frequent mutations are found in KMT2D and TP53. By gene expression profiling, most cases of high-grade B-cell lymphoma NOS have been reported to group into unclassified cluster, and remainder are variably classified in other clusters. Interestingly, gene expression profiling showed that 54% of high-grade B-cell lymphoma NOS harbor double hit signature, characteristic of large B-cell lymphoma or high-grade B-cell lymphoma with MYC BCL2 despite lacking rearrangement in these genes. So they are more towards unclassified category. And then they're usually, they show gene expression profiling similar to that double hit type. However, they lack the rearrangements of the MYC and BCL2. So that's about it. And Burkitt lymphoma, EBV matters. So now they are differentiating the EBV and non-EBV things in Burkitt. So definition of Burkitt lymphoma in Heme 5 remains largely unchanged, describing Burkitt lymphoma as aggressive mature B-cell lymphoma neoplasm composed of medium-sized cells with germinal center B-cell phenotype. So CD10 positive, BCL6 positive, BCL2 negative to weak, high Ki67 index, and IG MYC juxtaposition. Whereas 3 subtypes of Burkitt lymphoma was historically I recognized. So now they are not there anymore. They used to be endemic, non-endemic, or sporadic, and immunodeficiency associated. More recent data suggests that EBV positive Burkitt and EBV negative Burkitt form distinct biological groups based on their molecular features regardless of epidemiological context and geographic location, and therefore supersede the epidemiological subtyping. EBV infection plays an essential role in pathogenesis, causing B cells to evade apoptosis. Emerging evidence suggests a dual mechanism of Burkitt lymphoma pathogenesis. So virus-driven versus mutational. depending on EBV status. So that's that. And EBV positive and negative Burkitt lymphoma share evidence of coding mutations coding mutations affecting pathways such as BCR and PI3K, signaling apoptosis, SWI SNF complex, GPCR. In comparison with EBV negative, EBV positive shows significantly higher levels of somatic hypermutation, particularly in non-coding sequences close to the transcription start site. Harbor fewer driver mode mutations, particularly in apoptosis pathway, and shows lower frequency of mutations in the gene encoding transcription TCF3 and its repressor ID3. To acknowledge these recent insights into Burkitt lymphoma biology, the distinction of two subtypes, EBV positive and EBV negative, is now recommended by WHO Heme 5. So they have removed the endemic and sporadic and immunodeficiency associated, and now they are calling it BPV positive and negative because the mutation profiling and high degree of somatic hypermutations and so forth. Coming to the KSHV, HHV8 associated B lymphoid proliferations and lymphomas. WHO Heme 5 recognizes a full spectrum of lymphoid proliferation related to Kaposi sarcoma, HHV8, so Kaposi sarcoma herpes virus / HHV8 infection, which is parallel with the terminology of herpes virus. Other herpes virus is now indicated that KSHV / HSV8 to accommodate both the common practices of hematopathologist and of virologist. These lymphoid proliferations include, so basically that's the category KHSV / HSV8 associated B cell lymphoid proliferations, and these include the KHSV8 HHV8 associated multicentric Castleman's disease covered under tumor-like B cell predominance. So now these are covered under tumor-like predominance. We saw that. And then germinotropic lymphoproliferative disorders, primary fusion lymphoma, extracavitary primary fusion lymphoma, KHSV, HHV8 diffuse large B cell lymphoma. So all of these are under this category. So PEL, extracavitary PEL, and KHSV, HSV8, DLBCL characteristically seen in HIV, but can be seen in other immunodeficiency settings. KHHV8 germinotropic in contrast, is more prevalent in elderly without overt immunodeficiency, although it has been reported in HIV positive individuals as well. In addition, the KHSV / HHV8 MCD, what is MCD again? What is MCD again?
Multicentric Castleman disease.
Oh, okay, yeah. Multicentric Castleman's disease is seen in both HIV positive and HIV negative, but later are overall older. The diagnosis of prototypical examples of various KHSV / HHV8 associated entities is often straightforward based on definitions as formulated in WHO Heme 5. It has become clear, however, that morphologic and clinical spectrum of KSHV and HHV8 associated entities is broader than previously appreciated. Moreover, these are individual patients in whom clinical, histologic, and viral features, so HHV8 with or without EBV, overlap among entities. Observation of synchronous and metachronous presentations, different presentation of different KSHV / HHV8 associated lesions and cases that possess morphologic and or clinical features of more than one entity support that notion that these equivocal cases may result from special biology of KSHV, which is not adequately captured by current disease defining criteria. For example, distinction between lymph node based extracavitary PEL and HHV8 positive DLBCL is difficult and may be arbitrary. So WHO Heme 5 acknowledges the limitations of its definitions. While more data to support biologically defined boundaries amongst entities are awaited, it is recommended that decisions on classification of optimal therapy should be resolved in a multidisciplinary setting. Okay. So everything that we need to remember in this really is The KSHV, HSV8 associated B-cell lymphoid proliferations and lymphomas. They are separated from the others, and now they have lumped the germinotropic and PEL, extracavitary PEL, and the HHV8 positive DLBCL in here. And then the KHSV8, HHV8 associated multicentric Castleman diseases with the tumor-like lesions with B-cell predominance, as we saw earlier. And then they are clearly they are mentioning that these are the distinction can be difficult, maybe arbitrary, and they have kind of tried to differentiate them, but again, like there are restrictions to what they can do. And then lymphoid proliferations and lymphomas associated with immune deficiency and dysregulations. So first was the okay, mediastinal. Okay, so now coming to immunodeficiency, there are three categories, right? So they mentioned their lymphoid proliferations, lymphomas, and there was one more. So anyways, so immunodeficiency and dysregulation, a new approach to the order patients, okay, order patterns. WHO Heme 5 has introduced major changes to the classification of immune deficiency associated lymphoproliferative disorders. In prior classifications, these disorders were grouped according to the disease background in which they arose and were discussed as separate chapters. Primary immunodeficiencies, HIV infection, post-transplantation, and other iatrogenic immunodeficiencies. This approach has been valuable for many years in supporting clinical decision making and as a basis of translation and basic research. Now, knowledge that has resulted from this approach support the notion that morphological features to a certain extent the biology of many of these entities overlap, and that the spectrum of immunodeficiency setting is broader than previously recognized. So, therefore, it was considered timely to introduce an overarching framework as a standardized nomenclature to cover the different settings of immune dysfunction, according to unifying nomenclature proposed at the workshop on immunodeficiency and dysregulation, organized by Society of Hematopathology and European Association of Hematopathology in 2015. This framework aims to focus attention on shared histologic and pathogenetic features as well as to accommodate distinct causal association of specific lesion and specific clinical therapeutic consequences. So the new standardized nomenclature builds on an integrated approach to diagnosis that combines all relevant data into supporting systems. So there are histological diagnosis according to the accepted criteria and terminology, presence of one or more oncogenic viruses, and clinical setting or immunodeficiency background. The nomenclature addresses existing inconsistencies in terminology and diagnostic criteria for similar lesions in different immunodeficiency settings, may improve communication among the multidisciplinary teams in guiding appropriate clinical management as well as research studies, and facilitate incorporation of emerging knowledge in the field. As the same pathological entity, for example, PTLD does not necessarily have the same pathogenesis or clinical behavior in different immunodeficiency dysregulation settings. This underscores need to include immunodeficiency/dysregulation setting as required part of the three-part nomenclature. So new types of immunodeficiency setting continue to be recognized. So post-chemotherapy for treatment of solid tumors, hematologic neoplasms that has been largely accepted as underlying causes of immunodeficiency. However, it is yet unclear which polychemotherapy regimens confer this risk and how long the risk persists. In addition, with increasing use of novel immune modulatory agents, unanticipated types of immune dysfunction are emerging. For example, the aftermath of CAR T cells and checkpoint inhibition therapies. Immune senescence is another setting that is poorly understood and yet not possible to define or exclude. Thereby, use of an arbitrary age as cutoff does not have scientific basis. All these emergent concepts call into question of adequacy of the term immunodeficiency, which does not capture extent, depth, or phenotypic variation of immune suppression and the milieu of deregulated immune cell subsets. Therefore, Heme5 has adopted immune deficiency and immune dysregulation as preferred term to encompass the expanding disease spectrum. Primary immunodeficiency associated with germline mutations have been renamed as inborn errors of immunity by the International Union of an Immunological Society, a terminology that was adopted by Heme5. Patients with EIE, that is inborn errors of immunity, may develop distinctive type of lymphoid proliferations unique to the particular IEI, as well as those described in acquired immunodeficiency settings. The types and frequencies of these proliferations are largely dependent on immune dysregulation conferred by germline aberration underlying a respective IEI. Given the overlap with other IED settings, IEI-associated lymphoid proliferations and lymphomas has been incorporated into overarching frame and nomenclature of lymphoid proliferations and lymphomas associated with immunodeficiency and dysregulation. New approach to classification of IDD-associated lymphoid proliferations and lymphomas impacts other lymphoid entities that are described in separate WHO chapters. This especially holds true for diagnosis, in which EBV plays a defining or important role, including EBV positive DLBCL, lymphomatite granulosis, CHL. In WHO Heme5, harmonization of the diagnostic criteria amongst these categories has been undertaken as much as clinically feasible, while at the same time acknowledging that though some terminologies are arbitrary. For example, should an elderly patient with DLBCL harboring EBV diagnosed as EBV positive DLBCL or DLBCL, EBV positive in an IDD setting based on presumed immune senescence? Classification of these disease boundaries await further clinical pathological data and further insights into disease pathogenesis, which will allow evidence. So in this paragraph, all of this, they have just really emphasized that all the immunodeficiencies and the speculations, all the entities that were previously separated, they have lumped it together, and now they have been shown to have similar lesions in the immunodeficiency settings and so forth, and there are various examples of it. And now they are preferring to put it into the same disease spectrum. And then IEI, the inborn errors of immunity, basically now is also under this spectrum. And basically the nomenclature of lymphoid proliferations and lymphomas associated with immunodeficiency and dysregulation. And then they tell everything why it is lumped into one category. Hodgkin lymphoma, CHL, clearly defined from its mimickers. So NLPHL on the way to, but not yet, NLPBCL. So, but not yet. So it is not yet, it's still NLPHL. And so clearly defined from its mimickers. Let's see what they are saying.
Hi,
So
Akansha.
CHL, yeah.
I have a query. I mean, that KSHV, the lymphomas that they have been describing, like this associated DLBCL and the other one, primary infusion lymphoma, in which they are saying they're mostly occurring in the setting of HIV infection.
Mm-hmm.
So, and then they are describing these lymphomas associated with immunodeficiency or dysregulation. So, shouldn't those will be included in that category rather than this one?
So the HHV8 positive DLBCL, they are clearly mentioning that it will be in those HHV8 associated lymphoid proliferations and lymphomas. So over here, where do they say the KHHV8 in the immunodeficiency? You mean to say that it is HIV associated, that's why in the immunodeficiencies, that's why you're saying that?
Yes, because they are giving the example of this EBV positive and immune senescence. That's why I thought, why then KSHV is not included in this one.
So apparently, I mean, to my understanding, if it is HHV8 positive, just lump it into this category, despite if it is HIV or not. If it is HHV8 positive, just call it HHV8 associated B-cell lymphoid proliferations and lymphomas.
Now just have a look at the table 5. I mean, in there they are describing the viral association also, KSHV or HHV8 positive or negative. So there is some, I mean, confusion there, I think.
Yeah, that's true. So histologic diagnosis, hyperplasia, PTL, polymorphic lymphoproliferative disorders, mucocutaneous ulcers, and lymphoma classify as immunocompetent patients. Three-part nomenclature of lymphoid proliferation and lymphoma arising in immunodeficiency and dysregulation. EBV positive negative, KHHV positive negative, immune deficiency dysregulation type, inborn error of immunity, HIV infection, post-transplant, autoimmune diseases, iatrogenic therapy-related, immune senescence. Yep.
Akansha, where are you? Okay, on that table. Okay.
Yeah, I see. You see my screen?
Yeah.
Yeah. Yeah, I don't know. It's a little confusing. We can write to them. It's I agree that it's a little confusing. Yeah, I mean, if they have separated out the HHV8 associated, then they should not add the HHV8 association in here. Okay. Well, so another thing that we don't know, like the CLL with prolymphocytic progression, they were having some confusion there. So another one is here. Okay. All right. So we read this. Any other questions? So this is NLPHL. Okay. So NLPHL pattern A, B, C, D, E, F. This has been there since previously as well. And A is classic B cell nodular, B is serpiginous, interconnected, C is prominent extranodular, LP cells, D is T cell rich nodular, E is diffuse T cell rich B cell lymphoma or DLBCL like, and F is diffuse moth-eaten B cell rich. And we have nice pictures and everything in our book as well for this one. Okay. So CHL, now they are saying that they are clearly defined from its mimickers. Let's see what they are doing here. CHL comprises of a group of B cell neoplasm derived from germinal center B cells, characterized by low number of tumor cells embedded in a reactive microenvironment rich in the immune cells. The large diagnostic Hodgkin-Sternberg cells characteristically show a defective B cell program. The defining immunophenotype of Hodgkin-Sternberg cell remains unchanged from 4R, as are the criteria for nodular sclerosis, mixed cellularity, lymphocyte-rich, and lymphocyte-depleted subtypes. With modern treatment protocols, these subtypes have lost most of the prognostic significance. However, there is still merit in describing these subtypes to support epidemiological and translational studies, since specific subtypes are associated with different clinical features and underlying biologies. So they are still separating them as categories now. With basic description has not changed substantially since the last century. WHO Heme 5 includes comprehensive section on etiology and pathogenesis of CHL, in particularly incorporating new data on crucial role of microenvironment in modulating the disease. Recent biological insights have led to recognition of an expanding spectrum of pitfalls, gray zones, mimickers, among them nodular T follicular helper cell lymphomas and LPDs arising in immunodeficiency dysregulation settings that may contain EBV positive Hodgkin-Sternberg like cells. Okay. Caution should be exercised, therefore, when considering the diagnosis of CHL in the immunodeficiency setting. The same applies to purely extranodal CHL like lymphoproliferations. WHO Heme 5 continues to list NLPHL under the family of Hodgkin lymphoma. So I think the ICC has removed the NLPHL from the category of Hodgkin lymphoma. Is that correct? We'll read once we are
Yeah, I
doing
think they are
it.
calling it B cell lymphoma.
Yeah, right. So let me Yeah. So they are still continuing. So this is this is going to be confusing. They are still continuing as a family of Hodgkin lymphoma. The existing terminology of NLPHL is maintained so as not to interfere with ongoing clinical trials. However, NLPHL may be more accurately called nodular lymphocyte predominant B cell lymphoma, since the neoplastic cells has functional B cell program, and therefore this term is now considered acceptable in preparation of future definitive adoption of the new nomenclature. An important issue in NLPHL is recognized. Um, an important issue in NLPHL is the recognition of different growth patterns overlapping with T cell rich, histiocyte rich large B cell lymphoma, and at the extreme end. This patterns occurs across all age groups. Some variant patterns, for example, pattern C, D, and E, have been associated with more aggressive clinical behavior in retrospective analysis and may thus reflect the natural development and progression of tumor. In some cases, a clear distinction between NLPHL pattern E and T cell histiocyte rich B cell lymphoma may not be possible since both disease present with advanced clinical age. Distinction is especially difficult on small biopsies, which may not be representative. Plasma cell neoplasms and other diseases with paraproteins. New conditions from ASOP to TEMPI. Okay. So this is a new entity, plasma cell neoplasms and other diseases with paraproteins. The sections of plasma cell neoplasms in WHO Heme 5 recognizes new entities and incorporate structural modifications as step forward to Heme 4R. New conditions included are monoclonal gammopathy of renal significance, cold agglutinin disease, as well as TEMPI syndrome, which was provisional entity in Heme 4R, characterized by telangiectasias. So, telangiectasias, elevated erythropoietin and erythrocytosis, monoclonal gammopathy, peripheral fluid collection, and intrapulmonary shunting. And ASOP syndrome, that is adenopathy with extensive skin patch overlying plasmacytoma. Adenopathy with extensive skin patch overlying plasmacytoma. Section based on types of paraproteins and disease burdens have been recognized. So cold agglutinin disease, IgM and non-IgM MGUS, and monoclonal gammopathy of renal significance are grouped under monoclonal gammopathies. And diseases with, so these are monoclonal gammopathies, and diseases with abnormal monoclonal immunoglobulin deposits are grouped together. So basically those immunoglobulin deposition diseases. The heavy chain diseases are now included in the plasma cell neoplasm section. Mardala. Okay. So now the plasma cell neoplasms that are associated with other diseases that have paraproteins have a new name. So those plasma cell neoplasms that are having paraproteins, so that they have new conditions and including MGRS, CAD, TEMPI, and ASOP. And now the CAD, MGUS, and MGRS is monoclonal gammopathy. And then another group is abnormal monoclonal immunoglobulin deposits. And then the heavy chain disease is now included under the plasma cell neoplasm section. Okay. So now cold agglutinin disease. Now it is an autoimmune hemolytic anemia mediated by monoclonal cold agglutinins driven by an underlying clonal B cell lymphoid proliferation, not fulfilling criteria for B cell lymphoma. The annual incidence of this rare disease is estimated 1 to 1.8 per million. Its prevalence is fourfold higher in colder countries. Monoclonal gammopathy of renal significance represents a plasma cell or B cell proliferation that does not meet accepted criteria of malignancy, but secretes a monoclonal immunoglobulin or immunoglobulin fragment resulting in kidney injury. About 1.5% of those disease would otherwise be classified as MGUS have MGRS. So they have separated it out. Risk stratification of IgM MGUS and non-IgM MGUS have been updated. Presence of 3 risk factors consisting of abnormal serum free light chain ratio, IgA or IgM type risk with approximately 50 to 60% risk of progression at 20 years, whereas the risk is only 5% when none of these risk factors. So basically, they are stratifying it, the IgM and non-IgM MGUS. Diagnosis of TEMPI is primarily made on clinical and imaging investigations. The bone marrow is unremarkable in majority of the cases. A few cases show erythroid hyperplasia, low volume of light chain restricted plasma cells. Skin biopsies of patients with ASOF syndrome showed diffuse hyperplasia of dermal vessels associated with surrounding dermal mucin, and lymph nodes can show features mimicking Castleman's. Okay. New data have emerged concerning the progression from precursor states to plasma cell multiple myeloma, involving branching evolutionary patterns, novel mutations, biallelic hits in tumor suppressor genes, and segmental copy number changes. While 1q21 gain is often an early event, translocation and additional amplifications of 1q21 emerge later during the pathogenesis. Staging of plasma cell myeloma according to revised international staging system for multiple myeloma proposed by International Myeloma Working Group has been adopted. The role of minimal measurable residual disease using NGS, next generation flow cytometry or NGS, of immunoglobulin gene rearrangements, as well as PET-CT in assessing prognosis and risk stratification in patients with PCM has been detailed. Okay. Now coming to T cell and NK cell lymphoid proliferation and lymphomas. So before we dive into T cell, let's see what things we have missed over here, like these and these. So, okay, if we did this one, let's see this. So distinctive features of primary large B-cell lymphoma of immunoprivileged site. Subtypes are primary large B-cell lymphoma of CNS, vitreoretina, testis, these 3. And then these should not be immunocompromised. These patients should be immunoprivileged and immunocompetent, basically. And then clinical adults over age of 60, lymphoma tend to home to other immunoprivileged sites. Vitreoretinal tumor may occur concurrently with or follow the CNS tumor. Testicular tumor tends to relapse in CNS or contralateral testis. Aggressive tumors with generally poor prognosis. Morphology of large B-cell lymphoma. Immunophenotype, activated B-cell immunophenotype usually. So it will be ABC type, CD10 negative, MUM1 positive, BCL6 positive. And these are EBV negative. And mutational profile, concomitant MYD88 and CD79B mutations. Immune evasion. So genetic inactivation of MHC class 1 and 2 and beta-2 microglobulin with subsequent loss of protein expression. And showing DLBCL genomic signature, C5, MCD, and MYD88. Okay. Okay, so they have these 3 categories. They are adults over the age of 60, and they can interchangeably happen one after another, and in these sites, and then they are usually aggressive, poor prognosis, the morphologies of that of the large B-cell lymphoma, and they are ABC type, so basically CD10 negative, MUM1 positive, and BCL6 positive, EBV negative, and then they have more and MYD88 and CD79B mutations. Genetic inactivation of MHC class 1B and 1 and 2 and beta-2 microglobulin. Okay, and then the next one. Wonderful. Okay. WHO Heme 4R and WHO Heme 5. So the post-transplant LPD, non-destructive PTLD, polymorphic PTLD, monomorphic PTLD, and CHL PTLD. So now if they are differentiated, so now if there are more hyperplasias, for example in non-destructive and so forth, they are lumped into hyperplasias associated with immunodeficiency. So basically follicular hyperplasia, mononucleosis like hyperplasia, plasma cell hyperplasia, and KSHV8 associated NCD. So they are separating this out as well. Again, that's really confusing. And then polymorphic is now again polymorphic LPD, and EBV MCU. What is MCU again? Monoclonal something. Okay. And then
Mucocutaneous
CHL.
ulcer.
Mucocutaneous ulcer, right? Yeah. So polymorphic LPD and mucocutaneous ulcer are together. And then lymphomas. So if there are lymphomas, so then there are lymphomas associated with immunodeficiency dysregulation. So all of the lymphomas, also occurring in immunocompetent patients, HIV, specific to HIV, other immunodeficiency states. So all the lymphomas that have been associated with immunodeficiency states, all of those CHL-like and EBV and B-cell lymphomas and T-cell lymphomas, they are all lumped into one category. And even the neoplastic leukemias and lymphomas associated with primary immune disorders, all of them are lumped into lymphomas. So all the lymphomas that can happen in monomorphic PTLD or in immune deficiency HIV and the other LPDs, and then the primary immune disorders, immunodeficiency associated, all of them are LPDs, are lymphomas. And then they have separated out the IEI that they are calling inborn errors of immunity. And those are your LPDs that are associated with primary immune disorders. They have lumped it out into LPD. So those still, if it is immunodeficiency related, then it will be LPD associated with the immunodeficiency. And then specific to the IEI or inborn errors of immunity has been separated out. So it has been like, they think that they are making it simple with this diagrams, but they are making it even more complicated. Okay, just looking at this diagram gives me hypertension. Okay. And then we read this. Okay, now coming to T cell. So we did not read the T cell chart earlier, and there is this T cell chart. But we also did not read the CHL. So let's read the CHL first. So Hodgkin lymphoma, classic Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. There are two categories. And those classic Hodgkin lymphoma has all the other categories. Then plasma cell neoplasms and the other diseases with paraproteins has been separated out. Monoclonal gammopathies have been separated out. That includes cold agglutinin disease, IgM monoclonal gammopathy of undetermined significance, IgM, non-IgM monoclonal gammopathy of undetermined significance, and monoclonal gammopathy of renal significance. So previously, the cold agglutinin disease and MGRS were not included in the monoclonal gammopathies, but not only the IgM MGUS and non-IgM MGUS are there in the monoclonal gammopathies, but these two entities have been added. Then diseases with monoclonal immunoglobulin deposition. So the immunoglobulin related amyloidosis, which was previously called as primary amyloidosis, now they are calling it immunoglobulin related, especially AL amyloidosis. And then the MIDD, monoclonal immunoglobulin deposition disease, that were separated as light and heavy chain diseases. So now the heavy chain diseases have been separated out, and the monoclonal immunoglobulin deposition disease is there. So with the separate category of heavy chain deposition diseases, they are mu, gamma, and alpha. And then There is plasma cell neoplasm, which is plasmacytoma, plasma cell myeloma, and associated paraneoplastic syndrome, POEMS, STEMPI, and ASOP. So ASOP was not previously included. Now they have included the ASOP as well. Okay. Okay. So important to know that diseases of monoclonal immunoglobulin deposition has AL amyloidosis, and then monoclonal immunoglobulin deposition disease, but only the light chain apparently. The heavy chains have been separated out. And then there are plasma cell neoplasms. Okay. And then coming to the T cell. So again, there is a tumor-like lesions with T cell predominance, similar to what we had in the B cell. And now these include Kokichi Fujimoto, indolent T lymphoblastic proliferation, autoimmune lymphoproliferative syndrome. Okay. So Kikuchi Fujimoto, indolent T cell lymphoblastic proliferation, and autoimmune lymphoproliferative syndrome are separated out. And then precursors. So precursors TALL. So TLL NOS. So previously it was called TALL. Now it is TLL NOS. Early T cell precursor lymphoblastic leukemia, that was ETP lymphoma. So it was leukemia, it's leukemia previously, it is leukemia lymphoma now. And this NK lymphoma, good, very good. This NK lymphoblastic leukemia lymphoma has been deleted. So that's good because it was already very confusing and like it was hardly anyone was doing that anyways. And mature T cell and NK cell neoplasm. So now mature T cell and NK cell include T prolymphocytic is the same, T large granulocytic leukemia, so lymphocytic leukemia. So rather than T cell large granulocytic lymphocytic leukemia, they're calling T large granular lymphocytic leukemia. And then chronic LPD of NK, they're calling it NK large granular lymphocytic leukemia. And then ATLL is the same, Shizari is the same, aggressive NK cell leukemia is the same. And then primary cutaneous T cell lymphomas. So CD4 positive, primary cutaneous CD4 positive, small or medium T cell lymphoproliferative disorder is the same. The primary cutaneous acral CD8 positive T cell lymphoma has become LPD. Mycosis fungoides is the same. Primary cutaneous CD30 positive T cell lymphoproliferative disorders, LP, lymphomatoid papulosis is the same. CD30 positive T cell lymphoproliferative primary cutaneous ALCL is the same. Subcutaneous panniculitis like T cell is the same. Primary cutaneous gamma delta T cell is the same. Primary cutaneous CD8 positive aggressive epidermotropic cytolytic T cell lymphoma is the same. Cytotoxic T cell lymphoma. Primary cutaneous PTCL is NOS was not included. Now they are including a cutaneous PTCL. So primary cutaneous PTCL. And coming to intestinals, and indolent T cell lymphoma of GIT. So previously it was LPD, now they're calling it lymphoma. Indolent LK LPD of the GIT is another one. Then enteropathy associated is the same, monomorphic epitheliotropic is the same, intestinal T cell lymphoma is the same. Hepatosplenic is the same. ALK positive ALCL. So they used to have ALCL, ALK positive and ALK negative. Now they have included ALK positive ALCL and ALK negative ALCL. And then breast implant associated is the same. Now they have changed the nomenclature of all these three follicular types. So basically, nodal follicular T helper cells lymphomas, and they are now AITL is called as nodular TFH cell lymphoma, angioimmunoblastic type. Follicular T cell lymphoma is called nodal TFH cell lymphoma, follicular type. And then nodal peripheral T cell lymphoma with TFH immunophenotype. The peripheral PTCL now has become TFH cell lymphoma NOS. So they the PTCL is over here. The nodal PTCL is not nodal PTCL anymore. It became NOS. Then other PTCL. So PTCL NOS is the same, and basically they have dissolved the PTCL nodal type. Not dissolved, but basically made it NOS. And then EBV positive NK cell lymphoma. So this was not previously included. That is EBV positive nodal T and NK cell lymphoma. So they have included this category. Extranodal NKT cell is the same, just that they are not calling it nasal type. And EBV positive T cell lymphoid proliferations and lymphomas of childhood. So mosquito bite allergy is the same. Hydrovacciniform, like, they have removed the word like and hydrovacciniform. Chronic EBV infection in T cell and NK cell type systemic form, they are now calling systemic chronic active EBV disease. And systemic EBV positive T cell lymphoma of the childhood is the same. Okay. Okay, it might look a little overwhelming, but that's okay. Just a second. This in safe driving mode. Okay. You guys can hear me, right?
Yeah.
Truly speaking, they didn't make a whole lot of changes in the T cell, except that the NK lymphoblastic leukemia lymphoma is deleted. There are these tumor-like lesions with T cell predominance, and then some changes in the nomenclatures. And primary cutaneous PTCL NOS is a separate category. The nodal PTCL, they have dissolved into a PTCL into TFH NOLs. And then EBV positive NKT cell is nodal NKT cell is another one that have been added. And then in the GIT, they have added the NKLPD of the GIT. Okay. Yeah. So dendritic, we'll come back to dendritic. So they have included a littoral cell angioma, which was not in the classification before. They have a lot of questions in boards for littoral cell. They usually ask that littoral cell angioma. Okay. So anything to discuss before we dive into the T cells? Apart from that, we are kind of
Overwhelming.
yeah, that's the right word. Yeah, but I mean, when we were reading WHO, all these smaller chapters were overwhelming too.
Yeah, it takes a few readings before you're comfortable.
Yeah. Okay. Especially because they are not so like commonly seen, or commonly you don't see a lot of cases of these entities. So that becomes like the T and K, when we are going to have the TALL and then our TPLL, and thus we are going to have more interest in those entities. Okay. Want to take a break? 5 minutes?
Yeah, let's do that.
Yeah, let's do a 5 minutes break and then come back. We'll do the T cell and GIT, okay. And then yeah, so we have like 1, 2, 3, 4, 5, 6. It's almost 6 pages or 5.5 pages remaining. All right. So let's take a 5 minutes break. I'll come back and give your heads a little rest after all that things, like overwhelming things. I'll stop the recording and start the recording again eventually, okay?